This is Dr. Stanley Szefler, Deputy Editor for the Journal of Allergy and Clinical Immunology. And I'm here with Dr. Leonard Bacharier, and we're going to discuss two publications in the upcoming issue of the Journal of Allergy and Clinical Immunology. The article of interest is a article by Dr. Leonard Bacharier from the group in France and Australia with the Eden Mother-Child Cohort Study Group. And they have an upcoming publication entitled Cord Serum 25-hydroxyvitamin D and Risk of Early Childhood Transient Wheezing and Atopic Dermatitis. For this article, we found it very interesting in the editorial office and requested an editorial by Dr. Leonard Bacharier, who's the professor of pediatrics and medicine and clinical director of the Division of Pediatric Allergy, Immunology, and Pulmonary Medicine, and the unit co-leader of the Patient-Oriented Research Unit at the University of Washington in St. Louis and the Children's Hospital in St. Louis. And we've asked him to join us today to comment on his editorial. Dr. Bacharier, would you be kind enough to briefly summarize the key article by Dr. Bacharier that you provided your comment on?
Sure. Thank you, Stan. So this article really is the next installment in the emerging literature on the intersection between vitamin D status and the development of atopic disease. And this became an area of interest over the last decade as people began to recognize the greater than expected prevalence of vitamin D deficient states and realized that these were occurring in parallel to the increased prevalence of asthma worldwide, and began to examine whether these two conditions really had a biologic interrelationship. And there's been a lot of literature that's explored this, and one area of intense investigation has been whether the vitamin D status of an infant at the time of birth might influence their likelihood of going on to develop asthma. And there have been a couple of recent publications that have examined this, and while both of them have shown that low vitamin D levels may predict some atopic conditions and potentially wheezing, neither one of them were successful in demonstrating low vitamin D as a predictor for subsequent asthma. This group took advantage of the French-based Eden cohort, which was a birth cohort of over 2,000 mother-child pairs who were enrolled in 2003. And what they did was they took a subset of them for which cord blood was available at the age or at birth, and that comprised 239 out of the 2,002 individuals. They then examined cord blood 25-hydroxy vitamin D levels to asthma and allergy-related outcomes, in general assessed using the ISAC panel of questionnaires at ages 1, 2, 3, and 5. What they found was a reasonably high prevalence of vitamin D deficiency, with at least 50% of the study population having a level below 20 nanograms per ml. They found a predicted variation in vitamin D status by season of birth, as we know that children born in winter have lower vitamin D levels. They found that vitamin D levels were inversely related to the likelihood of transient early wheezing, so wheezing early in life but with remission and no recurrence, and an inverse relationship between vitamin D status and atopic dermatitis. However, when they looked for parent-reported doctor-diagnosed asthma or allergic rhinitis, they found no relationship between vitamin D status and either of those outcomes. So it's a study that in the end has shown that vitamin D status or vitamin D insufficient status is a risk factor for atopic dermatitis and wheezing early in life, but doesn't seem to predict the development of physician-diagnosed asthma or allergic rhinitis. And that's in general consistent with two of the more recent publications that have attempted to get at this question. The challenges with this study in terms of limiting their interpretation were that only about 12% of the original cohort is represented in this analysis, so it's unclear whether the same findings would have held if the entire cohort had serum or cord blood samples available for analysis. That is complicated by an 8% prevalence of asthma among a total of 239 subjects. So there were fewer than 20 asthmatics in the entire cohort being examined here, and therefore the power for detecting an association with an asthma outcome was relatively low due to the relatively low prevalence of asthma in this relatively small subset of an otherwise larger cohort.
Thank you. Are there any additional comments that you made in your editorial that you'd like to point out to our listeners?
Sure. So, when we look at this body of literature, there are a few elements of it that really don't fully reflect the question under study. Most, if not all, studies that have done this have taken a single measurement of vitamin D, be it at birth, be it at some other time point, and tried to relate that to some long-term or intermediate-term outcome. However, we know that can't be the only reflection of vitamin D status. It likely varies throughout pregnancy, and therefore multiple measures during pregnancy may allow for identification of a critical period during pregnancy at which vitamin D insufficiency may or may not have a greater impact. We really don't have a sense as to whether multiple measurements over time are going to be more helpful. Every patient in this study was recommended to receive oral vitamin D supplementation at a dose that wasn't clearly defined. So whether that impacted the outcomes seen here isn't entirely clear.
Thank you. As you look at this article and you reflect back on your editorial and the comments that you made very, very clearly, what do you think are the take-home messages, either for the clinician or for someone considering future research in this area?
So I don't think that the literature yet has given us clinical direction for folks to put into practice. The groups that are interested in vitamin D status in children have recommended that in children who receive less than 32 ounces a day of vitamin-fortified milk or formula, receive 400 international units per day of vitamin D. Until randomized controlled trials are completed either during pregnancy or during early life that clearly show impacts on either the prevalence or manifestation of the diseases of interest, I think it's still premature to recommend vitamin D supplementation above and beyond what is currently recommended by the American Academy of Pediatrics and the Institute of Medicine. I think we need to be cognizant of the prevalence of vitamin D insufficiency and keep our eyes on it, because we know that that has risk factors for impaired bone growth and bone health. But whether substantial supplementation above and beyond that which was recommended by the AAP at this point seems premature, and there are trials in progress that are really asking this question very clearly. And I think if they're able to demonstrate that an appropriate level of supplementation modifies the outcome, then I think there will be true clinical implications of those findings.
Dr. Bacharier, thank you very much for taking the time to prepare your editorial for our readership, and also for taking the time to join us today to discuss your editorial and your comments on the publication by Dr. Buys and in our upcoming issue of the Journal of Allergy and Clinical Immunology.
All right. It was my pleasure. Thank you very much.